Welcome to the second lesson on occlusion for the dental team and what is it and why do we care. And in this lesson I want to look at the connection between occlusion and the comprehensive exam. And so again, when we come back to our three circles, what's in the patient's best interest in doing our exam and treatment planning, we're looking at that bottom circle, which is really about the exam. And part of the exam is obviously identifying or taking a close look at all the components of the masticatory system, right? And the interesting thing about this exam is that dentists, and it's probably the same in your team as well or with your dentist, is dentists are very good at going right to treatment planning. If you showed us a model of some teeth or a photo of some teeth, or we looked in somebody's mouth, we're so good at going right to treatment planning. Like, oh, that's a great place for 2 implants, or oh, I'm going to do some monolithic ceramic dentistry there. And we just go directly to treatment planning, right? Well, it's tough to treatment plan if we don't have a diagnosis. And when we say we need a diagnosis, it's, well, a diagnosis of what? And now we come back to, again, the 4 components of treatment planning: aesthetics, function, structure, and biology. And a little aside here, actually, is that there's actually a nice little lunch and learn that goes into the 4 components of facially generated treatment planning. So I'm not going to go all into that right now. But if we have a diagnosis for the 4 components, we only get that diagnosis as if we've done a thorough exam. And so now let's talk about that thorough exam. And in that exam are all the components you see here. It's a nice history. It's an examination of the muscles and the joints and the dentition and the soft tissue and even models. Well, what I want you to see is in really all except for the photos of that list in our comprehensive exam, it's really occlusion. So basically, almost all of our comprehensive exam has to do with occlusion. I mean, even the patient's history. When you think about it, what we really want to know is, how did our patient get here? And oftentimes, the reason they have the dentistry they have or the experiences they've had has a lot to do with occlusion. And of course, we're going to look at the muscles, and we're going to look at the joints, and when we look at the teeth, is oftentimes the reason, most of the time, the reason the teeth look like they do or the restorations they've had has a lot to do with occlusion. And finally, those mounted models we'll take only because we're interested in occlusion. So again, you see that our comprehensive exam really is occlusally focused. So let's not discount that that's really, again, that overlying umbrella for our exam. So again, not to simplify too much, but when you really think about it, what is the goal of our exam? Or what can we think about when we're looking at the goal of our exam? And it might be to identify the safe patients we want to treat, so the ones that are more predictable, right? Or the ones that don't seem so safe or that are unpredictable. So when we think about the dangerous patients in our practice, really, who are they? Well, we can start with the bruxers, the patients who clench or grind their teeth, whether it be daytime or nighttime. I think of them as basically, I'm worried that I'm going to come in and do the dentistry, and there's one of those wrecking balls right behind me coming through and trying to destroy exactly what I put in there right after I put it in there. And so bruxers are definitely one of our dangerous patients we want to treat. But what about patients who really are having TMJ concerns, whether it be clicking or popping joints, painful joints, or some type of pain in and around the joint area? Those can be pretty dangerous patients to treat as well. Or patients who have a lot of breakdown, structural or periodontal breakdown. Very dangerous patients to treat, or let's at least say unpredictable. Now, the last category there with some, if they're psychologically challenged or you have some behavioral challenges, that's up to you to how many of those you want to treat. But certainly there are dangerous patients. But you look at the top 3, and again, it's all occlusally based. So if we have a thorough understanding of occlusion and do a great exam, we're now not going to be surprised by some things we didn't see during the examination. So as we go through and do our examination of the joints and muscles and teeth, and again, we're going to look into that in subsequent courses, but one of the things we can basically look at that we want to come up with in the end is the occlusion physiologic or pathologic? And if we can just come up and identify that, it'll help identify the dangerous patients in our practice. So let's spend just a couple minutes here talking about physiologic and pathologic occlusion, and look at the 4 components. It's really 3 components plus 1. But the 4 components are the joints. And so ideally, we have 2 temporal mandibular joints, and this is how we can talk to our patients. And ideally, the ball is in the socket. No different from our shoulders or our hips or our knees. We like the ball to be in the socket. The cool thing about the temporomandibular joint is that the ball is actually designed to come out of the socket. So every time we open, the ball comes out of the socket, and we bite back together, the ball should go back in the socket. And on top of the ball, we've got this cool little piece of cartilage that helps protect it so it can squish against the bone. But in general, ideally, in physiologic occlusion, we would like when we open the ball to come out of the socket, and when we bite back together, the ball goes back and gets centered in the socket. The muscles, as we bring the muscles into occlusion, we would like it so that when the muscles squeeze, so when they contract, it brings the mandible up, and it's the same on both sides, right? So that the right muscle is working in harmony with the left muscle to help bring the jaw closed with the ball in the socket. And when the teeth actually come together, so now we're into the third component, teeth. When the teeth come together, we would love it if all of the back teeth touched evenly and simultaneously. The back teeth touched a little harder than the front teeth. And when we moved our jaw from side to side with teeth touching, that our front teeth rubbed against each other to make our back teeth come apart. So in other words, immediate posterior disclusion, right? So we want the ball in the socket when we bite together. We want muscles working in harmony together. We want back teeth touching evenly and simultaneously. And we want our front teeth bringing our back teeth apart and guiding nicely so that they're rubbing against each other nicely. Let's throw in the periodontium just for a minute, because really, if that's not all working together, then oftentimes we can create some fremitus or loose teeth, or let's reverse that and think that if there are some loose teeth or some periodontally compromised teeth, that will affect the way that the stability of the teeth and the rest of the system. So physiologic occlusion is all of those components working in harmony together. So when all three or three plus components are working in harmony together, that's of course physiologic occlusion. And really when just one of those components is off, then they will affect the other three, and that's pathologic occlusion. So during our comprehensive exam, if we can at least identify if the occlusion is physiologic or pathologic, that in and of itself helps dictate predictable dentistry in the future. As we finish this lesson, I want to take a look at how physiologic occlusion has a positive effect on your practice, or how pathologic occlusion might have a negative effect on your practice and your patients. So when we have functional or physiologic occlusion, one of the benefits in our practice is that we have better patient comfort, or on our terms, less post-operative complications coming in and interrupting our days, and patients are happier. Our restorations also last longer, right? Because they function better, so they're not going to break down as quickly. The other thing is when you have physiologic occlusion, basically you have occlusal stability. In other words, the teeth are going to stay in the same place and things are going to last longer. Also, again, as we mentioned earlier, it's more aesthetically pleasing. Teeth that function well usually look good, and teeth that don't oftentimes don't. One of the most important parts of physiological occlusion in the practice is increased productivity in the office. In other words, we don't have to have those complications coming in and interrupting our day, so our productivity goes up. And probably the most important aspect of functional or physiologic occlusion in the practice is decreased stress in the office, or as we brought that word up earlier, predictability. Because what we want is to have more predictability. Lack of predictability is a direct correlation to burnout in the office. So what happens when occlusion is not functional or not physiologic? Well, I'm just going to put this list up and you can look at it as I read down it. But basically, pathologic occlusion is the top destructive dental disorder. It is also the top contributing factor to loss of teeth. In other words, when occlusion is poor, it leads to so many different ways of tooth loss. It's the top reason for needing, then, extensive dentistry because it caused the breakdown in the first place. It's the top reason associated with discomfort of the mascatory system, meaning the muscles and joints specifically. It's also the top factor in post-orthodontic instability. In other words, if even after you've had braces, if the occlusion is not great, you will have some post-ortho relapse. Teeth will move again. It's the top reason for tooth sensitivity and soreness, obviously, because that's when we have high fillings or complications after. It's also the top missed diagnosis leading to unnecessary endodontic treatment. In other words, so many root canals are done due to pain, that really is occlusally related, and the root canals were never needed to be done. And finally, it's the top undiagnosed dental disorder. Basically, occlusal disease is the top undiagnosed dental disorder. And so as we finish this lesson, I hope you have an appreciation for how occlusion and the comprehensive exam not only go together, but again, that occlusion is really that umbrella overlying the entire comprehensive exam. And I'll see you at the next lesson.